Tip it over.
Good evening and welcome. Tonight we will be talking about functional family therapy. Your therapists tonight will be myself, Irma Lucero, Lynette May, and Erin Moreno. Some of the resources that we've collected this evening come from the U.S. Department of Justice Office Justice Programs, the Center for Control and Disease Prevention, American Youth Forum, the U.S. Department of Justice, and Clark County Juvenile Justice Center. What is functional family therapy? Functional family therapy is a family-based prevention and intervention program that has been applied successfully in a variety of contexts to treat a range of these high-risk youth and their families. Functional family therapy, or FFT, draws on a multi-systemic perspective and its family-based prevention and intervention efforts. The program applies a comprehensive model, proven theory, and empirically tested principles, and a wealth of experience to the treatment of at-risk and delinquent youth. About FFT, this is built on an integrated theoretical foundation and systemic research evidence that demonstrates serious criminal behavior in youth. As a true family therapy, FFT targets the family rational system as a systemic and individualized treatment. In other words, not just working with the family, but the individual as well, setting and establishing treatment goals for each and everyone in the family. The clinical core consists of integrated set of guided theoretical principles, a systematic clinical intervention program that relies upon phase-based change mechanisms. These phase-based change mechanisms are three that we will be talking a little bit about. The first phase is the engagement and motivation phase. The second phase is the behavior phase. And the third is the generalization. Within these is the assessment and treatment as well. Finally, a systemic quality improvement system that monitors case planning and client progress throughout the client program is also proven outcomes throughout the system. Functional family therapy was developed in the 1960s and early 70s by Jim Alexander. How does the program work? FFT is based on the assumption that every family member's behavior serves as an adaptive function within the entire family system. Once the families understand the functional reasons behind their behaviors, they are in a better position to change them. Therapists facilitate this understanding through 4 different processes: increasing the family's motivation for change by forming positive alliance with each member and helping members form a positive alliance with each other. In other words, working on specific techniques such as communication, and we'll talk a little bit about motivational interviewing as well. Reframing the meaning of members' behavior to decrease blame and criticism. Helping the family identify small and achievable goals for change. The therapist matching their behavior to the behavior of the family to create a change in positive alliance that suggests appropriate options for change. And now here we have therapist Lynette to discuss a little bit more about FFT.
Conducted in clinical settings as an outpatient therapy as well as in a home-based model. It can be provided in a variety of settings, including schools, child welfare facilities, probation and parole offices, aftercare systems, and mental health facilities. In most programs, sessions are spread over a 3 to 6 month period. FFT is usually short-term, about 8 to 12 one-hour sessions for mild cases and up to 30 hours of directive service for more difficult situations. The idea is to engage and motivate youth and their families by decreasing the intense negativity, such as blaming and hopelessness, which are often characteristics of these families. Many times these families are paralyzed by the intense negative experiences, things like cultural isolation and racism, loss of deprivation, abandonment, abuse, depression. So the intervention program itself consists of 5 major components, in addition to pre-treatment activities. These are the engagement and change, motivation to change, relation interpersonal assessment, planning for behavior change itself, and then generalization across the behavior domains. So the pre-treatment has a goal of showing clients that you are responsive, timely, available, and have a positive mindset. In the engagement phase, the therapist demonstrates a desire to listen, cultural competence, and enhanced credibility with the client. This includes high availability, telephone outreach, appropriate language and dress, having adequate transportation, contact with as many family members as possible, and then matching, which is having a respectful attitude as well. Motivation phase, the goals are to create a positive motivational context, minimize hopelessness and low self-efficacy, and then change the meaning of family relationships to emphasize hopeful experience. The therapist's focus is on separating blame from responsibilities while also remaining strength-based. Activities include interrupting negative interaction, patterns of blaming, changing meaning through strength-based relational focus, reframing themes, and then for a positive future. The relational assessment, the goals include listening and in the behavior change phase, the goal consists of skill building, changing habitual problematic interactions, and coping patterns. Therapists focus on communication training using technical aids, assigning tasks, and training in conflict resolution. So activities are focused on modeling and prompting positive behavior, providing directives and information, developing creative programs to change behavior, and remaining sensitive to families' abilities and interpersonal needs. So the generalization phase is the last phase, and the primary goals are extending positive family functioning, planning for relapse prevention, and incorporating community systems. The focus is on relationship between family and members and community systems, and activities involve knowing the community, developing and maintaining contacts, initiating clinical linkages, creating relapse prevention plans, and helping the family develop independence.
What does the current research say about FFT? FFT is based on a number of scientifically proven theories of child development and therapeutic practice, including family systems theory, social learning theory, ecological theory, cognitive behavioral principles, and effective communication. A key feature of the program is the therapist's ability to match evidence-based strategies to the specific needs of each family. In our research, we found an increasing body of evidence-based studies in support of FFT. The California Evidence-Based Clearinghouse lists 8 studies, separate studies, and rate them as having strong evidence on the scientific rating scale. 5 of those are randomized controlled trial studies. We'd like to highlight 3 studies that show significant outcomes. Study 1, 114 substance misusing adolescents were randomly assigned to FFT, individual cognitive behavioral therapy, family therapy, and combined individual and family therapy, and a group intervention. The study then compared the groups in terms of percentage of days cannabis was used at 4 to 7 month follow-up assessments. The significant outcome of this study was that each intervention resulted in reductions in cannabis use, although there were differences in the specific outcome, speed of change and maintenance of change. Participation in FFT resulted in the most rapid change of all 4 conditions. Study 2, 95 youths arrested in serious offenses were randomly assigned to FFT and regular family case management. The reoffending rates for both groups were then compared 2 years following the intervention. At this time, the well-being of the mothers was also assessed and a number of standardized measures. At the 2-year follow-up, FFT participants were significantly less likely to have committed a crime. The mothers of the participants also reported less depression and anxiety. Study 3, the 18-month reoffending rates of juvenile delinquents receiving FFT therapy were compared to similar delinquents in a waitlist control group. The reoffending rates of delinquents participating in FFT were 30% less than those not receiving FFT. When practitioner fidelity and skill was taken into account, there was a 50% reduction in reoffending rates. Bringing it closer to home, the 2011 report to the Washington State Legislature that was completed by the Washington State Institute for Public Policy found that the FFT continues to improve the cost benefit to taxpayers of Washington State. For every dollar spent on FFT, $18.98 is saved through reductions in felony recidivism.